Welcome to the Rheumatology section of the Step 2 High Yield series. My name is Nick Sonpal. I'm a Chief Resident at Lenox Hill Hospital and Assistant Clinical Professor at Touro College of Medicine. We're going to begin with osteoarthritis, a condition that affects millions of Americans. Osteoarthritis, or degenerative joint disease, is a chronic, slowly progressive, erosive damage to joint surfaces. This loss of articular cartilage causes increasing pain with minimal or absent inflammation. The incidence of degenerative joint disease is directly proportional to increasing age and trauma to the joint. Contact sports with trauma early in life can lead to it later on. Modest recreational running does not cause degenerative joint disease. Obesity, however, does increase your risk of developing DJD. Remember, DJD is by far the most common cause of joint disease. Degenerative joint disease is most commonly symptomatic in weight-bearing joints, such as the knees, hips, and ankles. The hand is affected, but it does not cause a great deal of disability. The distal interphalangeal joints are more commonly infected in the hands compared to the proximal interphalangeal joints and the metacarpal phalangeal joints. A patient with osteoarthritis or degenerative joint disease will present with crepitations of the involved joints. They may have effusions, but they are rare. The stiffness is of short duration, usually less than 15 minutes. The DIP joints, when they're enlarged, are called Heberdine's nodes, and when the proximal interphalangeal joints are enlarged, those are called Bouchard's nodes. Here's an example of osteoarthritis of the hands. There you can see Heberdine's nodes at the distal interphalangeal joint, and there's a Bouchard's node at the proximal interphalangeal joint. When working somebody up for degenerative joint disease, laboratory tests are going to be normal. The ESR, CBC, ANA, and rheumatoid factor are all going to come back normal. The most accurate test is radiography of the affected joints. X-rays are going to show joint space narrowing, osteophytes, dense subchondral bone, and bone cysts. Here's an X-ray of the hip showing degenerative joint disease. The absence of inflammation, normal lab tests, and the short duration of stiffness distinguishes osteoarthritis from rheumatoid arthritis. Weight loss and moderate exercise are recommended for people with osteoarthritis. Hydrotherapy, especially swimming, has been shown to be beneficial. Acetaminophen is the best initial analgesic. NSAIDs are used when pain is not controlled with acetaminophen. Second line only because of their toxicity, particularly GI bleeding. Capsaicin cream has been shown to have some mild effects. Hyaluronic acid injections into large joints, specifically the knees, have been beneficial. Intra-articular steroids are only used if pain is not controlled, and a joint replacement is indicated if the pain and disease is truly severe. Remember, glucosamine and chondroitin sulfate are no more effective than placebo. Moving on, we're going to be discussing some of the crystal arthropathies. Gouty arthritis is a defect in urate metabolism. Currently, 90% of cases occur in men. The etiology is from two underlying issues. The first can be from overproduction of urate or simply from its underexcretion. The etiology of gout comes from the two areas I mentioned, overproduction and underexcretion. In the overproduction category, the first cause is idiopathic, which means we don't know why. The second is an increased cell turnover. This can be in cancer, hemolysis, psoriasis, or chemotherapy. The last is an enzyme deficiency, such as Lesch-Nyhan syndrome or glycogen storage diseases. In the underexcretion category, the most common causes can be renal insufficiency, ketoacidosis or lactic acidosis, or the use of a thiazide or aspirin. Remember, thiazides cause hyperglycemia, lipidemia, uricemia, and hypercalcemia, hypergluc. On the USMLE, you want to look for a man who's developed sudden excruciating pain with redness and tenderness of the big toe after a night of binging with beer. Fever is common, and it's difficult to distinguish the gouty attack from infection without an arthrocentesis. Although the metatarsal phalangeal joint of the great toe is most commonly affected, gout can be symptomatic in the ankle, feet, and knees. Here's an example of a patient who has podagra, or inflammation of the big toe due to gouty deposition. There are some patients who have gout all the time in a chronic nature. They have tophi, which is deposits of urate crystals with a foreign body reaction. Most often, tophi occur in the cartilage, subcutaneous tissue, bone, and kidney, but can take years to develop. Uric acid stones occur in 5 to 10% of patients, and long asymptomatic periods between attacks are common. Remember, tophi can occur anywhere in the body. The most accurate test for someone with gout is an aspiration of the affected joint. What you're going to find are needle-shaped crystals with negative birefringence on polarized light microscopy. In gout, the white blood cell count will be elevated between 2 and 50,000. The cell count will show predominantly neutrophils. Remember, it's going to be an infected joint with redness, warmth, and tenderness, so you're going to expect inflammatory cells. It's essential to tap the joint to exclude infection. Now here's a tip. Protein and glucose levels in synovial fluid don't help answer the most likely diagnosis question. Remember, it's not a lumbar puncture. There are other diagnostic tests we could use for gout. There's a uric acid level, which could be elevated at some point in 95% of patients. But keep in mind, if you check it just once, there's a chance that it'll be normal in about 25% of patients. In an acute attack, the ESR will be elevated, as well as a leukocytosis on the CBC. When getting an X-ray to diagnose gout, you must keep in mind that the X-rays can be normal in early disease, and erosions of the cortical bone only happen later, as you can see here in this image to the right. During an acute attack of gout, NSAIDs are superior to colchicine as the best initial therapy. If you have one joint and you want to consider a steroid injection, that's fine. But if you have multiple joints, do not consider multiple injections. Just go straight to systemic steroids. Steroids are always the answer when there's no response to the NSAIDs or there's a contraindication to NSAIDs, such as renal insufficiency. Now don't get worried about the exam. Contraindication questions are always clear and very much to the point. The chronic management of gout is a 5-pronged approach. The first is diet. We tell patients to decrease the consumption of alcohol, particularly beer. We tell them to lose weight and decrease high purine foods such as red meats and seafood. The second step is to stop offending agents such as thiazide, aspirin, and niacin. Remember, thiazides have 4 side effects you must know for the USMLE: hypergluc, hypergluc, hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. Third, we tell them to start colchicine because it's effective at preventing a second attack of gout. It's also effective at preventing the attacks brought on by the sudden fluctuations in uric acid due to starting probenecid or allopurinol. Fourth, we tell the patients that probenecid and sulfapyrazine increase the excretion of uric acid in kidneys. This is what we call a uricosuric. And the fifth prong is we start allopurinol. Allopurinol decreases the production of uric acid. So as you can see, we decrease the intake, we decrease the production, and we increase the excretion. You must know that colchicine gives diarrhea and bone marrow suppression, neutropenia specifically. Probenecid, NSAIDs, and sulfapyrazone are contraindicated in renal insufficiency. However, allopurinol is safe with renal injury. There are several adverse effects of chronic treatment that the USMLE loves to ask you. The first is a hypersensitivity to rash formation, hemolysis, allergic interstitial nephritis. These occur with uricosuric agents such as allopurinol. As we mentioned, colchicine can suppress white cell production, and you can actually develop a toxic epidermal necrolysis, or Stevens-Johnson syndrome, which could also occur from allopurinol. Remember, don't start a uricosuric agent or allopurinol during any acute attack of gout. If the patient is already on allopurinol, you can safely continue it. The next disease is calcium pyrophosphate deposition disease, known as pseudogout. This is not malingering in the sense the patient's faking having gout, it's actually a real occurrence. Now, pseudo-gout is when calcium-containing salts begin to deposit in the articular cartilage. The most common risk factor for it is actually hemochromatosis, and that's right, any condition in which you have high calcium levels, such as hyperparathyroidism. Calcium pyrophosphate deposition disease can occur in also patients who have diabetes, hypothyroidism, and Wilson's disease. Now, pseudogout differs from gout in that large joints are affected, such as the knee and wrist. You will very, very, very rarely see a patient come in with first metacarpal disease, as we are so commonly attuned in gout. It differs from degenerative joint disease in that the distal interphalangeal and the proximal interphalangeal joints are not affected. When diagnosing gout, remember the uric acid level is going to be normal. X-rays are going to show calcification of the cartilaginous structures of the joint and degenerative joint disease. The most accurate test is the arthrocentesis, and it's going to reveal this key phrase: positively birefringent rhomboid-shaped crystals. Remember that phrase for the USMLE. The synovial fluid aspirate will show an elevated white cell count between 2 and 50,000. But this is not going to distinguish pseudo-gout from gout or other inflammatory diseases of the joint, such as rheumatoid arthritis. It's the findings of the crystals that do it. Here's an image of positively birefringent rhomboid-shaped crystals. Here's an image of the calcification of cartilaginous structures in the knee joint. That's classic for pseudo-gout. What you must always keep in mind is you cannot confirm a diagnosis of calcium pyrophosphate deposition disease without aspiration of the joint first. Now I'd like to review all the joint diseases with you. Degenerative joint disease, in terms of history, will present as an older patient, slowing down and worsening with use. Physical findings will show involvement of the DIP, PIP, the hips, and the knees. Synovial fluid will show less than 200 white cells, osteophytes, and joint space narrowing. In gout, you want to look for a patient who is male, has had a recent acute binge drinking, consumes a lot of red meat. Physical finding, the classic, is the first big toe. And you're going to find between 2 and 50,000 white cells and negatively birefringent needles. When it comes to calcium pyrophosphate disease, you want to look for hemochromatosis or hyperparathyroidism in the history. The wrists and knees are most commonly affected, and again, you're going to see between 2 and 50,000 white cells, but you're going to find positively birefringent rhomboid crystals. That's going to distinguish it. Rheumatoid arthritis is usually going to be in a young female with morning stiffness that gets better with use. It's in multiple joints, it's bilateral, and it's usually the hands and feet. Remember, you want to look for the anti-cyclic citrullinated peptide. This is the most specific. Septic arthritis patients are going to present with a very high fever. It's going to be very quick, and it's going to come out of nowhere. It's going to be a single hot joint. An analysis will show greater than 50,000 neutrophils, and you want to culture the fluid, then start antibiotics. The treatment of pseudogout is going to sound very familiar to you. The best initial therapy, that's right, is NSAIDs. Severe disease that's not responding to NSAIDs will be given intra-articular steroids, such as triamcinolone. Now, for prophylaxis, colchicine does help prevent subsequent attacks.